ballpark range, so this looks promising. And this is the waterfall plot showing a number of good responses and also some complete responses, particularly in patients with tumor-associated BRCA mutations. And then even in those patients that were in the middle group that didn't seem like they had a great actual response, some of them actually were on drug for a long period of time. So the clinical benefit is something that does really look sustainable. So I'll close with this last kind of innovation that we saw. Another way to de-escalate therapy for our patients is potentially to, rather than giving chemotherapy freely, is to hinge it to some sort of Trojan horse type mechanism. And here, the perfect Trojan horses are the monoclonal antibodies. So we attach a very toxic chemotherapy to a monoclonal antibody, which is then directed towards some target inside a specific cell, ideally a cancer cell. So sacituzumab govitecan, or Immune-132, is a humanized monoclonal antibody that targets the TROP2 antigen, which is present on a lot of cancer cells. And it has SN38, also known as irinotecan, so a topo-1 inhibitor. And you'll see, unlike TDM1, which many of us use, the ratio of drug to antibody is substantially higher, so potentially a lot more oomph in this Trojan horse. So this was presented at San Antonio this year, and looking at specifically the triple-negative patients, 110 patients, greater than 2 prior lines of therapy. And you'll see an overall response rate for 34%, a median PFS of 5.5, and survival of 13 months. It's actually pretty good for this population. Grade 3/4 toxicities were expected for giving a chemotherapy like SN38, but generally considered manageable. Based on this data, the FDA offered a breakthrough designation and fast track designation for this molecule, and now there's a phase 3 trial going on. So this was not presented at ASCO this year. What was presented was another indication potentially for this, which is an hormone receptor positive disease, metastatic breast cancer. And when you looked at the original trial for this molecule, it was actually a basket trial with a bunch of different disease types, and we recruited to this actually. But under the other, this is the ER positive, HER2 negative. There are 54 patients who met this criteria. So this is what was presented at San Antonio. And this tumor waterfall plot looks kind of like the ones it does for triple negative. This molecule may actually not care if you're triple negative. It may just work well as long as the molecule that's being targeted by the antibody is present. And that's what this data suggests. So a clinical benefit rate of 50% in patients who'd actually seen quite a number of lines of treatment in the metastatic setting. So really, when I look at the summer and think about the updates from this summer, the word is de-escalation. So we learned that it's probably now not just based on the Oncotype data, but the MINDAC data, that there are patients who do not need chemotherapy with early stage breast cancer, and we have tools that better identify who those patients are. So that's one check mark. For our patients with HER2 positive disease, over the last several years, we learned anthracycline is not necessary for everybody. And even if we give them, now we're learning that perhaps we can get by with less trastuzumab, which is, I think, a win for our patients. And for patients with low-risk HER2-positive disease, we're already, many of us, giving taxanes plus Herceptin by themselves, sparing them of the anthracycline. And perhaps in the near future, we'll know we can do things like just giving them TDM1 without all the attendant toxicities of a conventional chemotherapy. In the triple-negative space, our reliance on just chemotherapy is going to be diminished. We have tools that we have shown in other disease spaces, such as the checkpoint inhibitors, to be able to spare a lot of toxicities for our patients. And now I think we're going to finally be at a point where we can achieve that for some types of breast cancers. And with respect to really the patients who have the horrible germline mutations that lead to these really aggressive breast cancers, whether it be BRCA1 or 2, we now have simple oral therapies that actually can be given at home in a tolerable way. So for me, the last year in particular, but I think in the last few years, has been about de-escalation of toxicities and now actual regimens for our patients. So I'd just like to thank the patients, obviously, who participate in these trials. Julie Graylow, who